Good morning. We are prepared to start day 2 of our PACCARB meeting. We had a wonderful meeting yesterday, capped off or started by approving unanimously our report on global opportunities for the U.S. related to antimicrobial resistance, and then some great panels. And today we have 2 additional panels that I'm really looking forward to. We're first going to learn more about the importance of or antimicrobial resistance in conflict zones and drug resistance. And then in the second panel, we'll be looking at unequal exposure, unequal risk, and environmental racism and drug resistance. And so I believe we have outstanding panelists and really look forward to the opportunity to visit with them, learn from them, and ask them questions. As always, I appreciate all the council members' engagement in these meetings and look forward to you asking questions, and want to express our appreciation to the PACCARB staff. With that, I'll see if Dr. Newland has any comments.
Yeah, thanks, Paul. I just want to say first thank you to our speakers who have come from near and far. If you remember yesterday when we approved our global AMR report, we talked about collaboration. We also talked about awareness. And one of the big parts about awareness was linking to larger issues within our society. This is that day. I mean, we're really going to do this in a way that I'm really excited to hear our speakers, and I really appreciate you all for taking the time to provide your expertise to us, PACCARB, and those who are listening. This is very important. And so I'm super excited to get our next thoughts and have the discussion later.
All right. Thank you, Dr. Newland. At this point, I'll turn it over to Dr. Musmar for our rules of engagement and participatory roll call.
Thank you, Drs. Plummer and Newland, and we appreciate everyone joining us again today for the second part of our 25th public meeting of the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria. As mentioned, my name is Jumana Musmar. I'm the designated federal officer and executive director for this advisory council, and I would like to sincerely thank all of our attendees and our presenters and our council members in particular for joining us today for today's discussions that go in a little bit deeper and based on the patient stories that we had yesterday. We're just delving into some of the topics that were brought up, and we hope that we have the same robust discussion as we had yesterday during our panels. As always, just to remind you all, the goal of this advisory council is to give the Secretary of Health and Human Services advice and recommendations to improve the programs and policies related to antibiotic resistance that would contribute to the overall health of our nation. To accomplish that mission, the Advisory Council strives to address the issues related to antibiotic resistance through a One Health approach, which is evident in all of our proceedings and products and membership. First, this meeting is being recorded and will be available on our website at HHS.gov/PACCARB. I will now go through a roll call for all council members. Please let us know if you're present by stating here, and for alternate representative members, please identify yourself and provide the name of the principal you are representing today. We'll start with our voting members. Dr. Paul Plummer.
Here.
Dr. Jason Newland.
Here.
Dr. Stephanie Black.
Here.
Dr. Claire Burbick.
Here.
Dr. Virginia Fate.
Here.
Dr. Susan Wong.
Here.
Dr. Jenny Kwan.
Here.
Dr. Brian Lubers, are you with us virtually?
I'm here.
Thank you. Dr. Lynn Marks.
Here.
Mr. Armando Nahom.
Here.
Dr. Payal Patel.
Here.
Dr. Robin Patel.
Here.
Dr. Joni Sheftel.
Here.
Dr. Julie Simzak.
Here.
Dr. Tom Whittam.
Here.
Excellent. Thank you all. Moving on to our liaisons. We know that Dr. Carla Houston for the American Association of Extension Veterinarians couldn't be with us. Dr. Padmini Srikantia for the Bill and Melinda Gates Foundation couldn't be with us today, but I wonder, is she with us virtually?
I am here.
Oh, fantastic. Thank you. Ms. Emily Wheeler for the Biotechnology Innovation Organization, BIO.
Here.
Thank you. Dr. Francisco Zagmut for EpiX Analytics.
Here.
Dr. Lucas Pantaleon for the National Institute of Animal Agriculture.
Here.
Dr. Libby Dodds-Ashley for the Society of Infectious Disease Pharmacists.
Here.
And Dr. Tim Jenks for the Wellcome Trust.
Here.
Thank you for being with us. Now for our RGEs or regular government employees, please indicate if you're covering for the principal RGE. For the USDA, Dr. Jeff Silverstein. Dr. Shively, are you with us on the line?
Dr. Chelsea Shively here on behalf of Dr. Sarah Tomlinson.
Thank you. Dr. Kiss Robertson Hale.
Dr. Kamala Fortenberry for Kiss Robertson Hale.
Thank you. For the Department of Defense, Dr. Paige Waterman. Oh, somebody said something. Hello. Is somebody on the line? Okay. Dr. Paige Waterman. All right. Moving on to HHS for the Administration for Strategic Preparedness and Response. Dr.
Jumana, I'm here. It's me.
Paige, is that you?
Correct, it's me.
Oh, okay. Thank you, Dr. Waterman. All righty. Back to ASPR. Dr. Chris Houchins.
Here.
Thank you. For the Agency for Research, Healthcare, and Quality.
Melissa Miller here.
Thank you, Dr. Miller. For the CDC, Mr. Michael Craig.
Here.
Thank you. For CMS, Dr. Sherry Ling. All right. For NIH, Dr. Dennis Dixon.
I'm here.
Thank you, Dr. Dixon. For OGA, Dr. Pat McDermott.
I'm here. I will have to leave before the meeting's over, and Angela Monahan should also be on for OGA. Thanks.
Okay. Thank you, Dr. McDermott. For the FDA, Dr. Bill Flynn.
Ricky Shawar for Bill Flynn.
Thank you, Dr. Shawad. And for the EPA, Dr. Jay Garland.
Here.
All right. Thank you all for attending this meeting again, and just a few more housekeeping items to remember. I ask that council members who wish to ask a question or have a comment to use their name card by propping it up vertically to raise your hand. The moderator for each Q&A session will call on you. Once you've been called on, please remember to unmute the microphone at your seat before speaking and then mute yourself following your comment and question. I'm also going to remind our council members that we're going to do a quick round robin, so please be sure to prepare your 45-second final thought. Keep it tight, but if not, it's okay. We still want to hear from you, and that'll happen towards the end of the day today. I now have the distinct honor of introducing Dr. Daniel Jernigan. Dr. Jernigan is the director of the National Center for Emerging and Zoonotic Infectious Diseases. Previously, he was the CDC's Deputy Director for Public Health Surveillance, Science and Surveillance, working at the intersection of public health, healthcare, and health IT to advance agency-wide science, surveillance, and data priorities and strategies. Dr. Jernigan, are you with us?
Yes, can you hear me?
Yes, we can hear you. Let's see if we can see you.
I can
see you.
Yes.
Welcome. Thank you for joining us.
Great. Thanks very much. And I think there are some slides that we're going to come up. Great. Yeah, thank you very much. Like you mentioned, I'm the director for the National Center for Emerging Zoonotic Infectious Diseases, where all of the antimicrobial resistance activities that really support the center and across USG and state health departments, et cetera, and even globally, all of that managed through our center. And I want to thank especially Michael Craig, who heads up a lot of that antimicrobial resistance activity and is with us here today. If you could go to the next slide. Antimicrobial resistance is an urgent global public health threat, killing at least 1.27 million people worldwide. It's associated with nearly 5 million deaths in 2019. And in the US, more than 2.8 million antimicrobial resistant infections occur each year, and more than 35,000 people die as a result. AR is a One Health issue, as was mentioned just a few minutes ago. It affects people at any stage of life, as well as animals and the environment, and more broadly, the healthcare, veterinary, and agriculture industries. This makes it one of the world's most urgent public health problems. When antibiotics and antifungals lose their effectiveness, we lose the ability to treat infections and control these public health threats. Already, antimicrobial resistant infections may require the use of second and third line treatments with the increased risk of harm. Caring for patients receiving care for serious health conditions such as cancer, organ transplants, chronic diseases, it depends on the use of antibiotics for success. If you could go to the next slide. Antimicrobial resistance poses a national security threat as well as a threat to administration priorities. Antimicrobial resistance can worsen pandemics, cancer, worsen chronic diseases. Increased AR is observed in conflict zones, as you'll hear a little later. Antimicrobial resistance can drain resources from economies, including healthcare, agriculture, and food production. And AR can also spread due to higher temperatures, with environmental reservoirs posing a risk to marginalized populations. Many factors influence the spread of AR, including food, water, and product contamination, lack of infection prevention, the lack of access to safe water, sanitation, and hygiene, inappropriate use of antibiotics, and global aging populations with more chronic diseases, leading to increased healthcare demand and more invasive procedures. If you could go to the next slide. So CDC's focus is on preventing infections from happening in the first place, and then detecting and responding to them as quickly and effectively as possible when they do occur. Drug and therapeutic development will always be needed, but we must remember that the best infection is the one that never happens. CDC supports global AR activities that detect and contain threats before they reach the United States. We sustain and grow national public health lab capacity. We prevent infections in healthcare and in communities. We improve the appropriate use of antibiotics and antifungals in humans, animals, and plants. We accelerate innovation of new strategies, tools, and interventions for AR in partnership with academic and industry partners. So CDC's efforts to combat AR are inherently collaborative, with work happening across the agency in 8 divisions in 4 centers and engaging dozens of partners in the U.S. and abroad. If you could go to the next slide. In September this year, there is a very important opportunity to demonstrate U.S. leadership in combating AR at the next United Nations General Assembly high-level meeting on antimicrobial resistance. This is a time for the global community to make specific, achievable commitments to combating antimicrobial resistance. Over the next months and at the meeting, the U.S. can demonstrate our commitment to combating the growing public health threat of AR domestically and abroad, and to join with global partners to advance our shared priorities, goals, and measurable targets. Next slide. Go to the next slide. For fiscal year 25, the President has put forward a plus up of $10 million for CDC's antimicrobial resistance initiative, and that's in the FY25 President's budget. With that increased annual funding, CDC will increase its investments in state, territorial, and local capacity to detect and prevent emerging and existing threats through strengthened infection prevention and control, antibiotic stewardship, data collection, and healthcare quality improvement efforts. We will also be able to strengthen global capacity to accurately detect AR threats and prevent infections through the global AR laboratory and response network and through CDC's regional offices and platforms. Through investments such as these, CDC is supporting the framework needed for global action to combat AR infections wherever they emerge and spread. This expansive work reflects cross-cutting initiatives across CDC and accelerated progress toward meeting the pivotal goals of PACCARB and the National Biodefense Strategy. Next slide. So there are both domestic and global activities with AR that CDC supports. CDC's Antimicrobial Resistance Laboratory Network, or AR Lab Network, was established in 2016 and supports public health labs in every U.S. state, as well as some large and cities and territories. This is done to rapidly detect antimicrobial resistance. These investments close the gap between local capabilities and the data needed to combat antimicrobial resistance in the U.S. The AR Lab Network has conducted more than 1 million tests as of 2023. Next slide. CDC's investments in health department and healthcare associated infection antimicrobial resistance programs and CDC's investments into the AR Lab Network also proved critical for improving lab capacities to detect and respond to outbreaks, such as the rare strain of extensively drug-resistant Pseudomonas aeruginosa associated with artificial tears. Here you can see an eye that has been affected with the Pseudomonas and a picture of the artificial tears, which actually originated in India, but was identified as a source of infection of Pseudomonas in long-term care facilities in the United States. This complex response highlights the value of CDC's national coordinated efforts to combat AR, CDC's investment in prevention, laboratories to detect, epidemiologists to respond, and infection control experts to stop further spread. That work likely kept this outbreak from becoming larger. However, this bacteria is still being detected in facilities, so something coming from around the globe now being able to cause disease in the United States and also continuing to be detected in some facilities. Next slide. So In terms of the global AR lab and response network, this outbreak of Pseudomonas also underscores why CDC supports global detection of urgent AR threats to help countries detect these novel forms of deadly resistance and stop their spread overseas and into the United States. For example, CDC's global AR lab and response network works in over 50 countries to help improve global AMR detection and response capacity. Through these global engagements, and with CDC support for prevention of AR in the US and abroad, we hope to prevent a future multi-resistant bacteria like Pseudomonas from emerging as a problem in another country halfway around the globe, to prevent the contamination of a medical product like artificial tears, and to prevent any subsequent infections and deaths here in the United States. Next slide. Later today, you will hear from Joanna Gaines, the Global Health Security Program Director for CDC Ukraine, who will share more about challenges associated with the spread of antimicrobial resistance due to the war in Ukraine. Antimicrobial resistance can spread rapidly during conflict with limited and disrupted access to water. Wounds are a breeding ground for antimicrobial resistant germs, and it clearly impacts healthcare systems that can then reduce healthcare safety. If you could go to the next slide. CDC's One Health Office supports implementation of the One Health approach across CDC and often plays a key role in coordination at the agency for cross-cutting One Health issues. CDC's One Health Office is currently the chair of the U.S. One Health Coordination Unit, or OHCU, a federal coordination platform used to strengthen One Health collaboration for the benefit of human, animal, and environmental health. And it can pull together working groups to address urgent needs and activities such as promoting health, enhancing health-sustaining resources, emergency preparedness, and the prevention, detection, and response to zoonotic diseases. Next slide. Outbreak response teams and CDC's National Center for Emerging and Zoonotic Infectious Diseases collaborate closely to provide technical assistance to health departments during outbreaks of carbapenem-resistant organisms in companion animals like dogs and cats. During the last 2 years, at least 5 outbreaks or transmission events have occurred in veterinary hospitals and 1 in an animal rescue facility. CDC's One Health Antimicrobial Resistance Program is working to understand the risk to humans when companion animals are found to carry CROs by initiating a project that would allow testing dog and cat specimens for these organisms in AR Lab network regional labs. Next slide. CDC's enteric zoonosis activity team continues to provide technical assistance and respond to outbreaks of AR enteric pathogens as well. In terms of fungal issues, combating antimicrobial resistance in fungi is a CDC priority. Fungal diseases such as valley fever, histoplasmosis, blastomycosis, and mold infections are also caused by environmental fungi that are sensitive to changes in climate. Invasive fungal infections present a greater threat now than they have historically because of an increasing vulnerability due to an aging population and increased use of biologics, leading to more immunocompromise. Invasive fungal infections can lead to severe illness, and mortality rates can reach 50% for some fungal diseases. Only 3 classes of antifungals exist that are effective for human use. Newer therapeutics are needed to reduce morbidity and mortality and mitigate the spread of antifungal resistance. Final slide. So in closing, I want to thank PACCARB and the members of the committee for your leadership in helping provide CDC and other agencies with feedback and recommendations. In this year's United Nations General Assembly high-level meeting provides a unique opportunity for world policymakers to come together and recognize the challenges that we collectively face with AR. I thank you all for your work on the report that was voted on yesterday and for your leadership in proposing the U.S. government take further action to address AR both in the United States and around the world. So thank you very much for the opportunity to speak.
Dr. Jernigan, thank you so much for joining us today and for sharing your knowledge with us. We appreciate you kind of teeing up the conversation that we're about to have in this panel. We hope you could stay with us on the line. And now transitioning over to our first panel of the day for conflict zones and drug resistance. We're delving a little bit deeper into something that Dr. Jarnigan just mentioned, but in addition to a comment that was made during the public comment yesterday as well. This represents a truly One Health environment that exacerbates the rate of AMR, and Dr. Susan Wong will be the moderator for today. Dr. Wong.
Thank you, Dr. Mismar. It's my great pleasure to moderate such a critically important and relevant topic. This panel will discuss the impact that conflicts have on the development and spread of drug resistance. And we have 4 esteemed colleagues with us today. Our first speaker will be Dr. Ghassan Abusita, from the rector of the University of Glasgow, followed by Dr. Suha Khanj, a professor of internal medicine at the American University of Beirut Medical Center. Then Dr. Johanna Gaines, the program manager of CDC's Ukraine Global Health Security Program. And finally, Dr. NG Hamed, the AMR technical advisor to the WHO Sudan Country Office. So thank you all for joining us today here in person and virtually. And please begin whenever you're ready, Dr. Abusita.
Dr. Abusita, were you able to join us online? I know that you had some technical issues. Okay, well, in the interest of time, Dr. Long, I think it's probably best that we continue on, probably by having Dr. Sahakan start, and then we can, once Dr. Abusita is able to join us, we can log back in.
Sounds good.
Thank you. Please transition the slides.
Good morning, everyone, and thank you for the invitation. It's an honor to be here today. So I'll be speaking on antimicrobial resistance and stewardship in displaced populations, focusing on the Middle East. Next, please. So these are my disclosures, but just to mention that none are related to this talk. Next. So let me start with showing some of the resistance data from the Arab countries. In 2018, I was invited by John Conley to write a review on antimicrobial resistance in the Arab countries, and it was quite a challenging task because while looking at the published literature, I realized that there weren't a lot of standardized regional and national AMR surveillance data, and there was a lot of variability in the published study. And nevertheless, with a number of colleagues, we put together, next please, the color-coded maps. And these maps show some of the resistance rate among the WHO critical priority pathogens, such as the multi-drug resistant gram-negative, as well as the high priority pathogens, such as Staph aureus and penicillin-resistant strep pneumo. And as you see from these color-coded maps, the darker the color, the highest the rates. 2 things are noticeable. First, we have very high rates of resistance among these pathogens in some of the countries, but also a lot of variability among the resistance rates, including in neighboring countries. Next. And we know that antibiotic consumption is one of the major drivers of antimicrobial resistance. And if we see at this data, we see that a lot of the Arab countries, whether they are classified as high, upper middle, or low middle income countries, they are among the big consumers of antibiotics. Next, please. But there are many other challenges that exacerbate AMR in the Arab countries. We have outpatient antibiotic prescription that is not controlled, patient self-prescribed antibiotics. There is a lack of antimicrobial stewardship program in the majority of hospitals, and those that have good programs, they are limiting their activities to the inpatient setting. And another major challenge is the transfer from countries that have very high rates of resistance. So even if you have good control on your own resistance rate, when you receive patients from neighboring countries, they will bring the multi-drug resistant pathogens to the hospitals. Next, please. This was a paper that was published 2 years ago looking at the national antimicrobial stewardship core capacities, and this was done by the WHO EMRO region office. And as you see here, the data is really quite disappointing. Not a lot of programs have national core elements, national plans and strategies. Only one country out of the 20 had dedicated funding for AMR and AMS activities. Only 4 out of the 20 had incorporated AMS criteria for hospitals accreditation. Next, please. And then comes the wars, and as we know, wars played a central part in shaping the modern history of the Arab world. Since 2001, the region has been one of the worst affected by wars. Next, please. And if we look at the numbers of displaced populations in the Middle East, it is estimated that in the Middle East North Africa region, as of the end of 2022, we had 15.7 million internally displaced people. This constitutes 26% of the global number of IDP, and it is the second highest concentration of IDPs following the sub-Saharan Africa. And as of since all the period till 2022, most of the displaced people had been triggered by armed conflict, particularly in 4 countries: Iraq, Libya, Syria, and Yemen. Next, please. And if we look at some of the refugees camps, and I gave here 4 examples from Jordan, Lebanon, Gaza, and Yemen, and there are many factors that are similar in these camps. There is overcrowding. These are inadequate shelters. There's insufficient nutrient intake, very poor vaccination coverage in all these camps, and very poor sanitation. And all this constitute a perfect recipe for infectious diseases in general. Next, please. But if we look at the problem of antimicrobial resistance during conflict, which is the topic of this presentation, in wars, we have high number of wounded people. The nature of the wounds and the injuries, devitalized tissues. We have loss of diagnostic healthcare personnel. We have under-resourced field hospitals taking care of these injured people, increased pathogen exposure, very poor infection control practices. A lot of the surgeries are done without attention to any aseptic techniques. And all this constitute what Shamila Devi labeled as AMR in the Middle East is a perfect storm. Next, please. This is a paper that was published in 2018 as a systematic review and meta-analysis on antimicrobial resistance among migrants in Europe, and looking at the rate of colonization or infection with multi-drug resistant pathogens. Among those studied, 25% had colonization or infection with MDRO, 27% were due to multi-drug resistant gram-negative. And if we look at the right side of the slide, we see that a large number of these screened were from countries in the Middle East, Syria, for example, a large number of infected or colonized patients with MRSA. Next, please. In this systematic review, they tried to look at antimicrobial resistance among glass pathogens in conflict and non-conflict affected settings in the Middle East. And as we see in blue is the fragile and conflict affected countries. Only 6 out of the 18 countries had adhered to the glass, and of those, only 1, Lebanon, is considered a fragile context. Next, please. Nevertheless, if we look at the data here, the rates over the years for E. coli, Klebsiella, Acinetobacter, and Staph aureus resistance are quite high. Carbapenem-resistant Acinetobacter, Bomanii, for example, median rate of 74%. Carbapenem-resistant Klebsiella, 15.4%. And they found that there were similar trends in conflict and non-conflict affected countries. Next slide, please. However, the lack of difference in AMR among the conflict and non-conflict affected areas is probably due to many factors, including the fact that the studies from conflict-affected settings tend to be less precise. Healthcare workers in these regions are focused on more saving life, paying less attention to AMR. But also one of the factors could be that there is lack of availability to antibiotic, which means we have less selective pressure on bacteria. Next, please. Let me start with an example from Syria. As you know, the war in Syria started in 2011, and the repercussions of war really go beyond the death, injury, and morbidity. Next slide. So there is really very scarce data published from Syria. Nevertheless, I summarized the data on the slide. The first one on the left, there is a paper looking at MDR organism, very low number of isolates, but enough to raise the alarm. A lot of resistance even among E. coli to ciprofloxacin, to carbapenems, very high rate of Acinetobacter resistance, including extremely drug resistant. As I mentioned, the number of isolate is low, but very alarming rates. And then there is a study that looked at injured people and the rates of colonization and infection with MDRO and found that 73% of those infected had infection with multi-drug resistant pathogens. And on the right side, this is data that I put together with Aula Abara, who works in the UK but is of Syrian origin. And from the data that we could gather, we reported that tigecycline resistance, for example, among Acinetobacter was 64%, but even colistin resistance in Klebsiella and E. coli, a drug considered to be last resort antibiotic, was very high, 8 and 9% respectively. Next, please. There are many drivers of AMR within Syria. A lot existed pre-conflict, and then some were exacerbated during conflict. And the consequences is that we have an inability to have any good surveillance study. We have very few operating microbiological laboratories, lack of quality control. We have smuggling of fake antibiotics, all this constituting really major risk factors for spreading of AMR. Next, please. But the displacement in Syria is not only internal. A lot of the Syrian displaced populations went to different countries. Turkey had the biggest share. Next slide. But also Lebanon, a country that's already beset by internal difficulties and very small country, received the second most large population of displaced people from Syria. Currently, it is estimated that Lebanon has the highest per capita concentration of refugees in the world, 173 refugees per 1,000 inhabitants. So currently, a quarter of the population of Lebanon is made of refugees. Next, please. And so Lebanon, despite all the difficulties, we have very good laboratories. We have state-of-the-art stewardship programs, state-of-the-art infection control program in some university hospitals. But this does not apply to all the hospitals across the nation. This is one example of multi-drug resistant pathogens that we've been tracking in my own hospital. And as we see the date fluctuate, but it's important to note that, as I mentioned at the beginning of the presentation, that we receive patients from neighboring countries with very high rates of resistance. So they bring these pathogens to us, and then we have a struggle to control the spread of these pathogens. One example is the first carbapenem-resistant Enterobacterialis that we ever saw in my own hospital were from Iraqi patients coming to seek care. Another study from Lebanon looking at Syrian refugees admitted mostly for war-related wounds to Lebanese hospitals found that the Syrian refugees were much more likely to be infected with carbapenem-resistant strains compared to the Lebanese patients, 74% versus 47%. Next, please. And there are many challenges for dealing with refugees in Lebanon. As you probably heard, Lebanon has had an unprecedented economic collapse. Since October 2019, the Lebanese pound had devaluated more than 90% of its initial value. A large number of the residents, including refugees, currently live in poverty, and they have significant barriers to access healthcare due to cost. One example of increased mortality from infectious diseases among refugees came from COVID-19, where Syrian refugees were found to be 4 times more likely to die than the national Lebanese average mortality rate. Next, please. Couple of words about Iraq, a country that has really been witnessing a lot of wars and conflicts over the year. I just like to mention that prior to 1970, Iraq had the most developed healthcare system in the Arab countries. But currently, they are struggling with AMR. The problem is we don't have local data published from Iraq. We have data published from returning soldiers, from Germany, from the US, etc., but not from local Iraqi data. One thing that is being now studied at the American University of Beirut is the effect of heavy metal toxicity in armed conflict, how it could be potentiating the multi-drug resistance among an organism such as Acinetobacter baumannii. And as you know, this was labeled at some point as Iraqi bacter instead of Acinetobacter. Next, please. And then came the problem of Gaza. I just like to mention that prior to the October 2023 Gaza war, 45% of the Gazan population lived in multidimensional poverty. In 2022, unemployment reached 45.3%. Next, please. And also, the data on AMR in Gaza is really very, very limited. This is just one published report looking at some multi-drug resistant pathogens. For example, Acinetobacter baumannii rates of resistance to carbapenem, 75% in 2020, 71% in 2022. Carbapenem-resistant Klebsiella pneumoniae, 22 and 25% respectively. So these are very alarming rates of resistance. Also, another report suggested that 34% of hospital waters could be contaminated with bacteria with high resistance to carbapenem and cephalosporins. Next, please. And since October 2023, more than 3/4 of Gaza's 2.2 million people are currently internally displaced. More than 1 million people are currently in Rafah, which is holding 5 times more than what it was holding before the war. The majority of hospitals are completely destroyed or rendered non-functional. The WHO Director General mentioned that in his speech yesterday. Perhaps only 5 partially functioning hospitals to care for the wounded. Next, please. And as we can imagine, all these factors, the influx of injured people, the breakdown of water and sewage, overwhelmed healthcare system, a lot of shortage of medical professionals, of equipments, of antibiotics, all this will fuel more antimicrobial resistance. And Christelle Musalli, an MSF worker, published an editorial in Lancet and really talked about it is futile and unethical to mention antibiotic resistance at this point because people are really struggling just to survive. But resistant bacteria will stay after the war, be present in soil and water, and cause difficult to treat infections. Next, please. And the Geneva Water Report, extensive document that was published recently, talks about the water and sewage mixing in Gaza and how this will create a problem in infectious diseases in general, but also antimicrobial resistance in particular for years to come, even after the war stops. And on the right side, we talk about One Health approach to AMR, and this is an example of how water and sanitation interventions are needed to block AMR between humans, animal, and environment, and the food supply. And so there is a lot of work that needs to be done. Next, please. There are many solutions that we can think of to talk about antimicrobial stewardship among refugees. For sure, we need to have better surveillance. We need to have more building of the capacity of the healthcare workers. We need to make available more microbiological tests. Think about point of care tests, rapid diagnostic tools. We need to improve quality control. And for all this to happen, we really need urgent collaboration among all stakeholders, including organizations, academic centers, NGOs, pharma companies, and many others. Next slide, please. And these are my concluding remarks here. AMR rates are very high, very alarming in the conflict region. Really, we don't have a lot of data, and we need to work together if we want to make an impact on antimicrobial resistance, which sees no borders for the hosting countries and then globally. Thank you very much for your attention.
Thank you, Dr. Kunch, for that incredibly sobering perspective and statistics in the Middle East. We will transition now to Dr. Abusita, War and AMR, a Surgeon's View. Dr. Abusita, are you there?
Yeah, can you hear me now?
Yes, we can. Thank you. Go ahead.
So thank you very much for this invitation. And really, as a simple surgeon, I need you to kind of move from the highbrow presentation of Dr. Suhakanj to the simpleton view of a surgeon on the ground. And so this is from my experience, having worked in the 5 wars of Gaza, including this one, and Mosul, and the war in Yemen and the war in Syria. Next slide. So just a quick intro. As you all know, blast injuries are either a primary blast injury, which is the expanding wave, secondary blast injury, which are missiles, and these missiles can either be inert, i.e. from the casing or the surrounding areas of the blast, or they can even be biological from other victims implanting into each other. And then tertiary, as the wounded are thrown against objects, and then quaternary, as buildings fall on top of them. Next slide. So we're going to start with your average, and this is from imagine one of the car bombs in Iraq or in Peshawar or anywhere in the region. Next slide. So you can see this is from Iraq. The idea that there is a point in which the environmental and the nosocomial end in war is really not very possible. Next slide. And then the point in which there's a hospital and then there's a community and there's a kind of discernible boundary also doesn't happen in conflicts. Patients are brought in and continuously accompanied by relatives, and they are looked after on the wards by relatives. Next. And then this is all happening and being treated whenever there is the possibility in hospitals that have no architecture of infection control. The majority of hospitals not just in Gaza, when Gaza did have any hospitals, but also in Iraq, in Syria, in Yemen, are the old-fashioned open wards where patients and their relatives and staff all mixed together with the bacteria, nosocomial bacteria, and the bacteria on the walls. Next. So when we think about the current war in Gaza, 75,000 wounded, well, these are wounds that by and large have not been reconstructed or closed. And so they are effectively 75,000 Petri dishes for the growth of bacteria. So I got into Gaza on the 9th of October, and as early as that following week, we had already had in the plastic surgery department over 120 patients who had exceeded the 24 to 36 hour recommended limit for debridement of war injuries just because the system had been so overwhelmed. And so you had lots of patients who were going into day 4, day 5 as early as the middle of October. And by the end of October, we were having patients who had been injured over 2 weeks before the time they managed to get their share in the ever-dwindling number of operating rooms. Next slide. And so these Petri dishes in the tens of thousands in Gaza, in Yemen, in Iraq, in Syria, are where these bacteria are allowed to grow. These war wounds, and particularly blast injury wounds, are perfect. They have the right mixture of moisture, of necrotic tissue, and of the helpful hand of the patient, the relatives, and the staff to ensure IPC is completely thrown out the window. Next. So what happens to antibiotic prescription in times of war? Next. So patients do not have access to a single antibiotic, and so antibiotics are chopped and changed. The antibiotic that's in the operating room is rarely the antibiotic on the wards when you send the patient back. It's rarely the antibiotic that the relatives find in the market when you try to discharge the patient. And this has been made much more acute in this current war. Next. As Dr. Kemj said, the number of, or the percentage of counterfeit and substandard antibiotics in times of war increases. I think in Iraq at one stage it's around 40% of all antibiotics were counterfeit. Next. And unfortunately, there is something that we call in war, in conflict medicine and humanitarian care, which is antibiotic dumping. And antibiotic dumping is when suddenly all of the pharmaceutical companies that manufacture antibiotics decide to send you one antibiotic that is 2 months away from expiry so that they can write it off as a donation. And so at the height of the marches of return in 2018, I remember receiving a whole consignment of a single antibiotic because that company just wanted to get rid of that antibiotic before it expired. And so suddenly you have that selection because everybody's using that antibiotic until that antibiotic runs out, and then another company sends you some more antibiotics of a given brand that they're trying to offload. Next. Dr. Kemj spoke about the destruction of the health system, and now it's most acute in Gaza. Of all of the hospitals in Gaza now, the European hospital is the only one that's partially working, and the rest are functioning hospitals are the field hospitals, which are small tented hospitals run by some of the humanitarian organizations, but the big hospitals like Shifa and Nasr, which constituted 45% of the system, have been completely destroyed. And even within the European hospital and some of the kind of partially damaged hospitals in the north, there is no running water. And colleagues told me that they were scrubbing purely with alcohol before surgery because there was no running water coming into the operating rooms. Next. So this is an interesting and for me a hypothesis that needs to kind of deserves further attention. We know that heavy metals play a critical part in the manufacture of the urban lived environment, in cement, in the piping, in the steel, in every aspect. And so what happened in Aleppo in Syria or in Mosul and what has happened in Gaza, where there's now 37 million tons of urban waste as a result of the destruction of 70% of the houses. That, for us, is a driver of heavy metal and metal toxicity into the soil. Next. And we know that the cobalt in a lot of the larger weight ammunition, the 2,000 pounders and the 1,500 pounders, co-selects for antibiotic resistance. We know selenium in the cement co-selects for antibiotic resistance. We know that copper in the piping co-selects in antibiotic resistance. And when you have over 7 months debris just sitting through the whole of the winter season, all of that makes its way into the aquifer and induces antimicrobial resistance in the existing environmental bacteria. Next. And so this is a kind of an attempt by a surgeon to come across as knowing the science that the infectious diseases people do, but effectively the message that I understand is that there's cross-resistance that happens as a result of heavy metals and antibiotics, and therefore the presence of this kind of environmental toxicity in all of the kind of wars in the region where a lot of the damage is happening in the urban environment. The presence of these heavy metals in the environment is playing a crucial role in the dissemination and the persistence of AMR. And then the broken down water and sewage treatment system is helping kind of spread that antimicrobial resistance even further afield. Next. And then hospital waste. There are two. There's the hospital waste that is as a result of the fact that in conflict, hospitals just throw their biological waste out with the normal rubbish. And, again, this was happening in Mosul. It's happening in certainly the hospitals that I worked in Sana'a and Aden in Yemen. And it's certainly happening now in Gaza. And as a result of the massive loss of life in Gaza, there's currently estimated to be around 10,000 people still buried under the rubble. And that constitutes an environmental catastrophe that will contribute to the spread of AMR in Gaza. Next. So we can see that in the ecology of war, and the ecology of war is a concept which basically challenges the idea that war is a temporal event. And it believes that war creates an ecology, a biosphere. And the biosphere is the combination of the social, the physical, and the biological. And that the patients who live in that biosphere, their health is injured and re-injured continuously as a result of that new ecology. And that ecology persists. It persisted in the south of Iraq, even though the war subsided much earlier than the rest of the country. It continues to be a major part in the majority of Syria, even the war has effectively subsided there, and it will continue in Gaza well after the end of this war. Next. And so war really constitutes the place where antimicrobial resistance thrives. And I believe that the kind of almost like the leaps in AMR globally have been triggered by the consequences of these major new conflicts, Iraq, Syria, and now Palestine. Next. And so we need to be very cognizant of the fact that this war in Gaza is about to unleash a major catastrophe in terms of the prevalence and the types of AMR. When I was in Ahli Hospital in October, I ran just a random 8 consecutive patients who had been referred to us from other hospitals. We did microbiology swabs, and all of the 8 patients had antimicrobial resistance. And this was back in October, early November. And therefore, reports coming from Israeli hospitals are not just reporting that almost all of the wound infections are multi-drug resistant, but that they're also seeing multi-drug resistant fungal infections. And they've had 2 fatalities from total multi-resistant fungal infections in Israeli hospitals. Next. The global deaths will increase beyond what was expected by the UN as a result of this current conflict in Gaza and other conflicts that are happening. I believe that these conflicts are force multipliers. Next. And, one of the previous speakers stole my thunder by talking about the perfect storm. Literally, the war is the perfect storm for everything that we think is a driver of antimicrobial resistance, all happening at once. Human behavior leads to antimicrobial resistance and conflict. The breakdown of the lived environment leads to an increase in antimicrobial resistance and conflict. And the health system, rather than treat, becomes a major driver of antimicrobial resistance and conflict. Next. Thank you very much, and I hope I haven't overrun.
Thank you, Dr. Abasita. Really appreciate the discussion of those many drivers of antibiotic resistance in war. We'll now turn to Dr. Johanna Gaines from the Center for Disease Control and Prevention on rising rates and increased geographic spread of resistant infections from the war in Ukraine.
Good morning. I'm Commander Joanna Gaines, and I currently serve as CDC's Global Health Security Program Director for Ukraine. I appreciate the opportunity to share with you today an overview of CDC's work to combat antimicrobial resistance in Ukraine. This is a complex effort involving the CDC Ukraine Country Office, our regional office, and our subject matter experts within CDC's Division of Healthcare Quality Promotion. We also have multiple implementing partners for our work, including Columbia University and the World Health Organization. It's an honor to represent them here today. Next slide, please. I'd like to provide you with a bit of background on our office and our work. In 2010, the CDC Country Office in Ukraine was officially opened. The office was part of our division for global HIV, AIDS, and tuberculosis, and their work was funded by PEPFAR. After our office was established, CDC was able to provide additional support to other areas, including vaccine-preventable diseases and workforce development. On February 24th, 2022, Russia's expanded invasion began. Please note, I call this the expanded invasion as Russia had previously invaded Ukraine's Crimea in 2014. The impact of the current war has been horrific. Approximately 1 in 3 Ukrainians are displaced, some internally, while others have fled the country. Exact estimates on casualties are not available, but the U.S. government estimates that approximately 100,000 Ukrainians have been killed. Further, Russia has targeted and destroyed critical infrastructure, including hospitals and hydroelectric dams in their campaign of terror against the Ukrainians. It is estimated that nearly 1 in 10 hospitals in Ukraine have been damaged. And the picture on the right shows an ambulance that Russia destroyed. You can find several of these parked outside of Ukraine's Ministry of Health, a stark reminder of their daily reality. Next slide, please. Ukraine experienced high rates of AR prior to the 2022 invasion. In 2019, 8,400 deaths were attributable to AR and 31,500 deaths were associated with AR. The graph on the right shows the number of deaths along the x-axis and the cause of death along the y-axis. Antimicrobial resistance was the third leading cause of deaths. In the red are the deaths associated with AR, and the black represents the deaths attributable to AR. Next slide, please. Unfortunately, Russia's 2022 invasion has actually accelerated the AR problem in Ukraine. In late 2022, point prevalence surveys at 3 regional hospitals found 14% of patients had at least one healthcare-associated infection, or HAI. 60% of these infections were due to a carbapenem-resistant organism, a type of deadly drug-resistant bacteria that are resistant to some of the most powerful antibiotics of last resort that we have. Klebsiella pneumoniae bacteria are one of the most common of these bacteria. Among 20 Klebsiella isolates identified in this point prevalence survey, all 20 were resistant to third-generation cephalosporin antibiotics. 19 of the 20 Klebsiella isolates were tested for resistance to carbapenem antibiotics, and all 19 were carbapenem resistant. These rates are substantially higher than those reported from a 2016-2017 European Union-wide point prevalence survey, which included more than 300,000 acute care hospital patients and 100,000 long-term care facility residents across the region. Amongst those respondents, that study found a healthcare-associated infection rate of 5.5%. Among the subset of infections caused by the Enterobacteriales family of bacteria, which includes Klebsiella, 6% of those isolates were resistant to carbapenem. Next slide, please. Pathogens don't need passports. After the invasion began, the war in Ukraine has led to migration of scores of people from Ukraine, as well as medical evacuation of those wounded. In March of 2022, about 1 month after the current invasion began, the European CDC issued guidance to their member states, highlighting this risk, stating that in people presenting with traumatic wounds, healthcare providers should be made aware that infections associated with these injuries can often include infection due to multi-drug resistant organisms. Diagnostic and treatment procedures should therefore be appropriate for identifying and managing such organisms. Subsequently, European surveillance systems have identified increased cases of infection and colonization with multi-drug resistant bacteria in patients from Ukraine. While most of these cases are being reported out of neighboring countries such as Poland, Hungary, and Lithuania, others have been reported elsewhere across the European Union and as far away as Japan, demonstrating the risk that AR poses to countries around the world, including the US. Slide, please. This AR spread has important global implications. For example, the Netherlands, which is a country that has a low prevalence of multi-drug resistant organisms, published a report last year of a more than 200% increase in carbapenem resistant bacteria, with 21% of those associated with Ukraine. Additionally, countries are reporting increases of what are normally rare AR genetic mechanisms, such as the carbapenemase producer NDM1 or dual producing NDM1 with OXA48 Klebsiella pneumoniae. The report here shown from Germany showed an unprecedented increase in this normally rare AR combination. The global implication is that the war in Ukraine is not only amplifying AR in Ukraine, it is fueling the AR fire in other countries with increased rates of AR and increasing reports of new and emerging AR types. Healthcare networks in Europe now consider prior hospitalization in Ukraine to be a critical risk factor for colonization of AR bacteria and require preemptive isolation and screening for colonization upon admission to European healthcare facilities. Slide, please. These infections are costly to treat in every sense of the word. They require more extensive surgeries and longer hospitalizations. AR infections are associated with higher rates of amputations and higher mortality rates, up to 50%. Patient outcomes are also worsened by the fact that Russia's war has complicated access to rapid high acuity care. Due to the heavy use of drones and missiles, air evacuations are extremely limited. Wounded soldiers and civilians must be brought back from the front lines and may be shipped further west to finish treatment and recovery. In the paper from the Netherlands on the previous slide, the authors noted that no outbreaks occurred in any of their facilities, indicating that infection prevention and control measures were functioning adequately. In short, prevention is key, both on the front lines and in hospitals. The paper on the right, as well as the papers previously discussed, includes data on patients that are carrying multiple types of resistance genes. The paper on the right is a case that was actually treated at a U.S. military facility in Germany, where the providers isolated 6 different extensively drug-resistant bacteria from one wounded soldier. This underscores a particular risk of leaving AR unchecked and unmitigated, which is the opportunity for patients to be exposed to and then harbor multiples of resistance at the same time, a deadly recipe that can lead to infections for which we have no remaining antibiotics left to aid in saving a patient's life. As evident in this case report shown, this risk is particularly high for wounded Ukrainian soldiers. This makes the AR crisis in Ukraine not about just saving individual lives in the hospital. Rather, it is important for winning the war against Russia. Addressing the AR problem is a key component of force protection. Soldiers that are infected with resistant organisms require longer treatment and recovery times, slowing their return to the battlefield if they can return at all. Slide, please. CDC has provided significant support to Ukraine for their AR response and recovery. We were asked by the Ukrainian government to establish a scalable model for hospital-based AR detection and response. This initiative had 4 goals. First, to reduce deaths and disability associated with war-related wound infections. Second, to improve detection and response to AR in healthcare facilities and public health centers. Third, to develop a costed, bottom-up approach to building surveillance programs for AR and hospital-acquired infections. And finally, to connect Ukraine with European and U.S. expertise, creating a stronger system overall. This map highlights the areas where CDC is currently working with the Ukrainian government, as well as denoting areas of conflict, primarily in the east. The star represents the capital city of Kyiv, home to Ukraine's National Public Health Institute, and hopefully the future home of their National Reference Laboratory. The 3 dots on the left or western side of the map represent our pilot sites located in the cities of Khmelnytsky, Ternopil, and Vinnytsia. Slide, please. At the national level, CDC primarily focuses on policy, systems, and response. We work alongside the Ukrainian government to help them craft policies and guidelines that are consistent with their current needs and future goals, such as EU accession. CDC has invested in AR surveillance and detection through developing and improving their electronic information systems, not unlike CDC's own data modernization initiatives. We have also worked to help them develop laboratory referral systems and implement quality management programs. CDC has also provided them with pathogen identification equipment and testing materials. On the response side, we have supported the Ukrainians in infection prevention and control, as well as their appropriate access to and use of antibiotics. One of the most unique things that CDC has been able to do is facilitate collaboration between groups at different levels, both inside Ukraine and outside. We work closely with WHO and heavily engage with them on AR work. We also currently host twinning calls between clinical providers in our own Department of Defense and Ukraine. Slide, please. At the oblast level, which is basically a state, we directly engage with healthcare facilities and regional public health centers in 3 locations. Each pilot facility has created their own multidisciplinary team to address the complex problem that is AR. Members include epidemiologists, physicians, and laboratorians. We've also ensured each hospital has appropriate protocols for detecting AR infection, and we will begin supporting AR colonization screening in the coming months. CDC works to improve data systems to allow for rapid reporting of AR to clinicians from laboratories. This allows for appropriate IPC efforts for patients. We also provide training in the fundamentals of prevention, such as IPC and antimicrobial stewardship. CDC provides support to the regional public health centers, or RCDCs. These facilities provide referral testing and supportive supervision to the pilot hospitals, as well as coordinating and collaborating AR efforts between the higher national level and the more local facility level. We hope to broaden our support to additional oblasts, but this is dependent on funding. Slide, please. No quick or easy solutions exist for solving antimicrobial resistance. Addressing the AR threat requires significant behavioral and cultural changes in a system that is already under significant stress. It is a complex problem that requires complex capacity building and system strengthening. Interministry collaboration is required, particularly in the arena of information sharing. The rapid distribution of information about AR when detected is essential, especially when patients may be moved to another facility for treatment. We also note the need for broad implementation of improved infection control practices, both in and outside of the hospital setting, especially inside and outside of the hospital setting, especially as soldiers may move from military treatment facilities to civilian facilities. From the front lines to rehabilitation facilities, all healthcare providers in Ukraine should be working to prevent the spread of AR. Of note, mis and disinformation pose a threat to both the U.S. and Ukrainian efforts to reduce the spread of AR. The U.S. government has provided essential support to quickly identify dangerous pathogens, not create them. Any other story is an outright lie. Slide, please. In summary, a challenging problem has become a public health crisis as a result of Russia's 2022 invasion. It has increased the burden of AR within Ukraine, as well as increasing the risk for the development of new and emerging antimicrobial resistance. AR poses a unique threat to civilians and soldiers alike, as well as to Ukraine's ability to win the war. AR can impact military readiness, making it a national security issue. Moreover, it is a threat most immediately to U.S. allies in Europe, as well as to Ukraine's ability to win the war, and the U.S. itself. A global surveillance has demonstrated the exportation of AR associated with Ukraine to neighboring countries and beyond. Lastly, this is a very human and financially resource-intensive problem that will require a sustained effort by the U.S. and our allies to prevent further spread of very difficult-to-treat AR infections. Slide, please. Thank you.
Thank you, Dr. Gaines. I just want to remind all speakers to please stay online for the Q&A at the end. And now to our last speaker, Dr. N.G. Hamid from the WHO, Understanding the Health and Drug Resistance Consequences of the Conflict in Sudan.
Good morning, everyone, and thanks for the invitation. I'm really honored that I'm here. First of all, I would like, if you allow me, to share not only the Sudan country experience as in the impact of the conflict of antimicrobial resistance, but also as my personal experience. Before joining Sudan country office, I used to work in the WHO, the Eastern Mediterranean region, for about 6 or 7 years. I supported many countries in the region: Egypt, Jordan, Iraq, Tunisia. And then when I got the post in Sudan, and this was through a special initiative that the WHO decided to have a dedicated officer or, advisor for antimicrobial resistance in some of the country offices to push the AMR agenda there. And actually, I was worried by many people that it's going to be very challenging in Sudan. But I said that I'm already used to working in the region. It shouldn't be that different. But actually, I learned it the hard way that it was really very different and difficult. And that's why, though at the WHO, we have the policies and we have the guidance, for the implementation of different programs, the IPC, the stewardship and everything. But again, the implementation is different from one country to another, even if we're talking about conflict countries. I supported Iraq in some of the projects there. And actually one of them was supported by the US CDC. But when you come talking to Sudan, it's totally different. So what I really want to share with you is, again, my personal experience to show you the Sudan status before the conflict and after the conflict and how it really affected the AMR program there. So next slide, please. So Sudan is considered a fragile country by the World Bank, even the early of the 2000s. And Sudan's population is around 50 million people. It's one of the largest countries, actually the second largest country in the region. It's about 2 million kilometers for the area. And the health system is mainly dependent on the primary healthcare facilities. We have about 6,000 all over the country. And actually, before the recent conflict that erupted by April 2023, there was a military coup in 2021. And this was followed by imposing sanctions. And sanctions mean that you have low donor fundings. And actually, the donors that are there in the country or on the ground are mainly supporting what they call the responding to the humanitarian crisis. AMR is not considered one of them. It's usually like a developmental issue. So whenever you go and talk to people or, to donors, even UN agencies, AMR is not on the list. And maybe we can have the support of the PACCARB in this, especially at the presence of the USAID in some of these countries, that AMR is really vital, in the conflict. So even before the war, I can just, the recent conflict, that around 85%, there was a survey conducted, 85% only of the healthcare facilities were accessible. This was even before the conflict, the recent conflict. The next slide, please. So the WASH facilities, about 12 million people, they hadn't any access to safe drinking water and toilets. Again, this is before the conflict. 25% of the water sources, they were not functioning. On the other side, vaccination was one of the areas that witnessed a remarkable improvement in the few years preceding the recent conflict, where you can see that vaccination coverage was almost, compared to other African regions, was much better. Next slide, please. So the pre-conflict disease profile, you can see that we have some of the infections were such as the HIV. Sorry, can I see? Yes, the HIV, diarrheal diseases, lower respiratory tract infections. They were among the three top diseases or infection causing most death in Sudan. And there were always outbreaks, many outbreaks. We had measles, though we have vaccination coverage and the vaccination campaigns were going just as fine, but we had measles outbreaks, malaria, about 87% of the population were classified to be at high risk, the dengue fever, and actually just before the conflict, the dengue fever was also expanded to new geographical areas that we didn't witness before the conflict. Next slide, please. And of course, there was the cholera. Sudan experienced more than 17 outbreaks of cholera from the duration from 1966 to 2022. TB incidents, actually Sudan is one of the countries receiving the global funds. The service for the TB patients were going fine. We just had like 300 testing centers. TB was well covered before the conflict. We suffered from the typhoid. And for the typhoid, we had the problem of the diagnostic. We didn't have any exact figures. The testing capacity of the country was very limited, and the doctors really depended on the Beadle test, which is, of course, as you know, is not the gold standard. There are very limited data on the sensitivity. And we had diphtheria outbreaks with about reported 105 cases. Next slide, please. So the availability of the medicine and the supply chain, also this was a UN report that the availability of medicine, it mainly depended on the donors and the UN agencies and the different NGOs that were working on the ground in Sudan. And I was surprised actually that we usually know that fragile countries or conflict-affected countries like Sudan, we usually suffer from access to certain antibiotics, but you'll be surprised that you can easily get colistin there in Sudan, or third-generation cephalosporins. As you're gonna see in the next slide, that we wanted to know what is actually being prescribed or, okay, that's the slide. So access, sometimes what we would like to call as excess or unregulated access, can sometimes be a problem in such countries. And it's not only in Sudan, we've seen it in other countries in the region. And this is, of course, due to the lack or, the absence of national regulatory authorities. And usually most of this broad-spectrum antibiotics. They are substandard or, counterfeit, but they are there in the country and they are widely prescribed and used by the patients. What we try to do, whereas at the WHO, we try to assess the capacity as a part of the EMR program to assess the capacity of the national laboratory there. But unfortunately, after assessment, it has very limited capacity for microbiological testing, though you'll be again surprised that they have all the fancy equipments. But due to the sanctions, they cannot either, get the supplies or the kits to operate it, or they don't have the biomedical engineer to maintain it or install it. So sometimes they have the devices or they have the equipments there. But again, maybe it's not the solution for them. And, after long discussions with the ministry and that, we found that, reverting to manual techniques may be more efficient for the country. Next slide, please. So, the pre-conflict, we conducted a survey for the antimicrobial prescriptions patterns, and this was mainly for the PHCs, because again, these were, the most accessible healthcare facilities to patients, and this was conducted in 325 primary healthcare facilities for all over Sudan, representing the 5 regions there. And as you can see, that the results that about 20%, 1/5 of the prescribed antibiotics, they were third-generation cephalosporins. And this was actually prescribed and administered to patients. And you can even see some carbapenems, though it's only 0.5%, but some PHCs, they had carbapenems there, and they were actually prescribed and again administered to patients. Next slide, please. Okay. Then the conflict and the war erupted in April 2023, and it's not being bad enough, but actually it got worse after the conflict. It's about 1/3 of the population that are now facing acute hunger, and reports are saying that Sudan may witness one of the worst famines in the modern history. It's about 25 million people now are in need. The health needs, 15 are require health needs, but we can only, as UN agencies, target 5 million. And this is mainly due to the issues in access to some sectors or some regions in Sudan. We have 2 regions, Darfur and Kordofan. They are totally non-accessible by any of the UN agencies. We try to deliver some of the support through cross-border, through Chad, but again, the borders were closed due to some political issues. So far, the fatalities are reported 14,000, but these are again underestimated. About 65% of the population, they lack access to any sort of healthcare facilities. There is, of course, a disruption to the supply chain. About 25%, only 25% of the need of the populations are being responded to. 70 to 80% of the healthcare facilities are not functioning, again, due to many reasons, due to the ongoing conflict, the non-accessibility, there are no supplies, no healthcare workers. And there has been so far 62 attacks against healthcare facilities, including hospitals. Next slide, please. So the post-conflict disease profile, actually, it hasn't changed much, from the pre-conflict. We're just seeing more cases. It's the cholera, the dengue, the measles, of course, due to the interruption of the vaccination campaigns, the malaria. But again, we know that we're facing underreported cases, again, to the same reasons. There are no internet connections. Sometimes there are no just even, telephone or, any network. The brain drain. Now there are a lot of the healthcare workers that are just leaving the country or they are inaccessible. So these are the numbers that are being reported, whether to the Ministry of Health or to the WHO. Next slide, please. So we're now having reports of poliovirus type 2, and this is in poor Sudan, meningitis, There have been reports of patients having fevers and convulsions, and this is even in the capital, Khartoum. But again, due to the inaccessibility, it's difficult to obtain a specimen. And of course, there's no functioning lab so far. Again, we're having typhoid and diphtheria reports. Next slide, please. So, one of the main impacts of the conflict on the healthcare services is the destruction of the Central Public Health Lab, though it's not was well functioning before the conflict, but even the equipments there and the supplies, the rapid diagnostic tests, they are inaccessible. The ministry and the WHO, we try to have like 2 or 3 other hubs across the country, but as the conflict is moving from one state to another, it's difficult to sustain their presence, and they are like just mobile labs. Of course, there's no salary for the government staff now for over 1 year, and staff, they are less motivated, to work and to be engaged on the ground. The interrupted vaccination campaigns for polio and measles, and that's why now we're witnessing more cases for both diseases. And all funds that, again, before the conflict, the Sudan Country Office, we were supposed to receive the MPTF funds, but of course, with the eruption of the conflict, all funds now are directed to respond to the humanitarian crisis. And again, AMR is not being seen as a priority. Next slide, please. And as we're talking about AMR and the One Health approach, Sudan actually have about 140 million livestock, and is considered one of the biggest livestock exporter in the region. And with the eruption of the conflict, there were, we're afraid that we have the central veterinary lab there that was actually providing vaccinations to the livestock. But of course, again, it was destroyed and it was seized by the military porters. And there were fears that, some of the equipments that being stolen or looted, that they might pollute, polluting the surrounding environments with the leakage of with some of the pathogens. And of course, now one of the biggest problems that the country is facing is the interruption of the livestock vaccination, especially for brucellosis. And WHO, together with the FAO and the other donors, were trying to address this issue. And one, again, of the impacts of the conflict is the displaced millions of livestock that forced them to new territories and new geographical areas, which, of course, will increase the contact between the livestock and, and people there. And next slide, please. Thank you.
Thank you, Dr. Hamid. While you are thinking about raising your attempt cards or signaling online for questions, Dr. Paul Plummer has a general comment.
Well, I want to thank all the speakers for your valuable contributions to the Council's understanding of antimicrobial resistance as it relates to conflict zones. It's important to recognize that we've discussed a number of conflicts today during this panel that may have personal sensitivities. And I would like to remind the Council that as a Federal Advisory Council, our role is to focus on the science of AMR, independent of global politics. So I would ask the Council members to focus our questions on the scientific aspects of antimicrobial resistance and to refrain from questioning or commenting on the underlying geopolitics of these conflicts we've discussed today. I'll start with my first question, or with a question. And so as we think about these conflict zones, my sense, certainly in the U.S., we're very concerned about rapid diagnostics and rapid therapeutic intervention. And in many of the examples given today of these conflict zones, there's delayed ability to respond for a variety of reasons. Disintegration of healthcare services, safety, inaccessibility of antibiotics. So just interested in if any of the panelists have comments on prioritization. Do we need better alternatives for kind of universal pan treatment type of approaches? I mean, are we pushing empirical therapy that can be applied quickly in the war zone and then evacuate these individuals? Or how do we think about traditional stewardship approaches in these conflict zones and how rapidly we can respond with an antibiotic therapy?
Thank you. Yeah, if I may start. So I think we really need to think outside the box of like what can be done differently. And you started by saying that the ability to diagnose the problem is very, very important. I think there are some organizations that have attempted to do work on point of care testing. For example, Médecins Sans Frontières have come up with this application, Antibiogo, they call it, where you take a picture of the slide and within few minutes you get your answer, what is the susceptibility profile, even if you don't have a lot of knowledge on site of the people who can tell you what is the resistance, etc. So in terms of diagnosing, I think there are some things that can be done. In terms of treatment, I think rather than, applying a protocol for, one type of drug or combination that would treat everything, I think Dr. Gaines gave an example of one patient having 6 different pathogens at the same time. One thing we're trying to do, and I'll mention this work we've done with GARD-EP, is try to think of what can be done, thinking outside the box of like a hub and spoke mechanism where you bring to every country even the most advanced, the most novel antibiotics, but you reserve them in one university hospital that can dispense these drugs as needed for these multi-drug resistant pathogens to anywhere within the same country. So these would be my initial thoughts. Thank you.
Dr. Jenks?
I want to thank all of the speakers. The presentations certainly provide a different focus on the impact of AMR and drivers of AMR and something for us to consider in terms of what solutions might be necessary. Before I ask my questions, I think it's worth pointing out that the Council on Foreign Relations currently tracks that there are 54 active conflicts that are state-related, but there are actually 182 armed conflicts ongoing in the world today. The UNHCR is tracking 108 million people in the world. That's over 1% of the global population who are forcibly displaced. And I think this is something that we have to be very aware of. And the frightening aspect of this is in the last decade, that population has nearly tripled. So there's been a hockey stick uptick in terms of the change in that population level in the world. So what we have are vulnerable people, vulnerable populations increasing in number. And this is something that is an amplifier of AMR and the spread of AMR. And that's why this council needs to consider why this is important and what to do about it. So I'd like to hear some views that take us beyond why, it can't be too difficult, and it's not just about humanitarian response and how we can think about it in terms of the public health response. And if any of the speakers could offer solutions that we should be looking to push and prioritize. And ideally, is there anything immediate that we should say, look, there is something available or nearly available that should be prioritized now? And what should be considered over the longer term, which should be part of a public health response alongside humanitarian crisis response? Thank you.
Dr. Obisita, would you like to respond?
So at the moment, around 80% of survivors that reach hospital are musculoskeletal injuries. The rest in these low hospital settings don't make it. And so we're really looking at soft tissue infections and osteomyelitis as the main cause of morbidity in AMR-related infections. And I think one of the issues that Dr. Kent spoke about, which is point of care immediate diagnostics, and the second one is non-systemically given local solutions, i.e., these glass beads that now are emerging as a treatment for chronic osteomyelitis, topically applied solutions that treat bacterial infections, because if we just keep chasing the antibiotic wheel, we're just going to keep ending exactly in the same place. Because now, as all of the speakers before said, as back as 10 years ago, we knew that patients in Iraq can go to any pharmacy and get a third generation antibiotic given by the pharmacist. And Professor Omar Dewashi, who at Rutgers recently finished a survey looking at Mosul, where actually the pharmacists are so in control as the center that they rent out the clinic space to internal medicine doctors in outpatient settings. And so, if we just drive more antibiotics, we're just going to get exactly where we were. And so topically applied and point of care diagnostics.
Dr. Hamid.
Thanks. So actually, I would like to highlight that what we call the cold zones, maybe the non-conflict zones. Again, in a country as large as Sudan, we have 18 states. Not all of the 18 states are engaged in the conflict, but you have like about 7 or 8 states. But they are affected indirectly by the conflict through the unaccess to the healthcare. So what WHO we're trying to do, we have the community healthcare workers. Sometimes they are forgotten, but mainly they are the main providers for the healthcare there. Again, I said we have the guidelines, we have the policies, but again, it's very much complicated and sophisticated for these healthcare workers, because sometimes, to be honest, in some countries, they don't have even the ability to read well, So this is one of our main focus areas too, as you were discussing yesterday, that prevention is the key. Okay, so how to deliver simple prevention messages to these healthcare workers who are really in contact with the population there. And again, the healthcare kits, again, as a WHO or UN agencies or the other NGOs, we are responsible, again, as you've seen the numbers for Sudan, for about 70 or 80% of the medication there in the country. But sometimes we're being guilty of, again, just providing this very limited number of antibiotics with no, again, guidance or instructions for healthcare workers how to use them or how to dispense them for certain or specific diseases. The most commonly seen ones like respiratory diseases, lower respiratory infections, or diarrheal infections. So I think, again, this could be like more of the areas that could be targeted in such countries, again, away from the conflict or the conflict wounds overtake. Thanks.
Dr. Khan.
Yeah, just to add on what else can be done, a model of train the trainer has been attempted in Yemen, where you train someone in stewardship and infection control. That person will train the rest of the healthcare workers in the country, but also you keep this online communication with that trainee to ensure that they are able to meet the challenges. If they have new questions, new challenges, you help them sail through these challenges. So that's another model that has worked in some of the conflict area in the Middle East.
Dr. Newland.
Yeah, thanks to all the speakers. Very sobering. As a pediatrician, I noticed that, we kind of just talk about the conflict impact as a global. Could you give some specific examples while I can come up with what I think is probably happening? Can you give some specificity to the impact on children in these conflict zones?
I can actually speak a little bit about that from what we've seen from Ukraine. It's interesting to note, I think sometimes when you look at the literature, there's a presumption that when you look at these conflicts, that the AMR is seen exclusively in sort of the war wounded, right? But it's not. We know from Ukraine, for example, some of the cases linked to Ukraine, which sort of drive this recommendation of if you've received care at a hospital treatment facility in Ukraine, you should be considered essentially at risk for being colonized. That was based off of the fact that some of this resistance has been seen in pediatric patients that were oncology patients. So these are essentially medical refugees who have received healthcare within a system that is under so much strain. If it had problems before, those are definitely going to be exacerbated. And then those patients are now presenting for care elsewhere. This was noted, I think, by every other speaker here. The movement of patients, not just of people, is a specific risk factor. And there is evidence to show that we're seeing this in pediatric populations.
Dr. Ganj?
Yeah, thank you. This is a very important question. So for what we are seeing in Lebanon, for example, from the Syrian refugee camps, we see a lot of drug resistance scabies where, you know, you treat them with several regimens and they don't respond. We had outbreaks of cholera, a huge outbreak of hepatitis A. I think in Gaza, in addition to all of the above, the infections in the amputated wounds is a major problem. And I think Dr. Abusetta can speak more about that. And I think in general, all infections due to vaccine preventable diseases tend to be very, very common in refugee camps all over the Middle East. Over.
Dr. Abusetta?
So in the Yemen war, 30 to 40% of the wounded are children. In Gaza, it's 50%. This is a region where the majority of the population is young, and therefore this is being reflected in the prevalence of injuries in children. And again, the majority of these injuries are within the survivors are musculoskeletal. And so we have a lot of as Dr. Kent said, we have we estimate now around 4,000 pediatric amputations, a lot of problems with wound dehiscence, and we have a lot of incidences of osteomyelitis. A colleague working in the MSF unit in the northern part of Gaza is now reporting that half of his amputations are on previously reconstructable limbs because osteomyelitis and deep wound infection has set in, and these patients were unable to access proper treatment in time. And so the reflection of the population means that pediatric multi-drug resistant war injuries are actually half of all of the injuries that we see.
We have multiple questions here and online, so we'll extend our Q&A period. Dr. Pantaleon.
Thank you very much for such an enlightening talks. And I was thinking, you know, we've been discussing in our council the lack of access to antibiotics in some of these, you know, displaced areas and conflicts. And then I was wondering, you know, when I saw the report of the high number of CREs or VREs, I was thinking if, you know, antibiotic use is one of the main drivers of increased resistance, you know, where is this resistance coming from if we had a lack of access? But I guess I understood, or that question was a little bit clarified by you guys by talking about these heavy metal toxicity and potentially cross-linking, the fact of the ecology of war. So that those were kind of enlightened concepts that I never thought about it. And then, you know, the fact that, as you mentioned, in Sudan, there was prior to the war, there was, you know, even counterfeited antibiotics were used. So that probably contribute to the high rate of, you know, infections. And then the other role is, you know, potentially, if you think about as a veterinarian, the displaced small animals in a war zone. And we discussed yesterday the role of small animals. And I wonder how colonization of some of these street dogs or cats now that have been abandoned, what role could they play in transferring some of these multi-resistant infections? So if you have any comments, appreciate it.
Go ahead.
Yes, thank you for the comments. So I give you an example. One professor in agriculture at the American University studied the presence of multi-drug resistant bacteria in chicken, and he found that a very high number of these chicken were colonized with colistin resistant E. coli, because a lot of the animals are being fed colistin to grow. And so I think there are multiple factors driving AMR, and not just limited to human use of antibiotic. It's also a lot of environmental exposure, but a lot of animal feeding with antibiotics. So I think all these factors are really contributing to this high level of resistance. I think one alarming thing that we're seeing now is that for the carbapenem-resistant Enterobacterialis, we've seen a shift to more metallo-beta-lactamases, which are, bacteria that don't have too many options to treat. With the limitation of the novel drugs available in some of the countries, this really, present a huge challenge for treatment. But as I mentioned, we're working on trying to acquire some of these novel drugs, but to have them under controlled use, so we make sure only the patients who absolutely need them get them, regardless of their socioeconomic status, whether they are refugees or not, etc.
Thank you for that. Sorry.
Yeah, go ahead.
If I could add on, I know some of what we've seen in Ukraine is, I think this relates to some of the challenges in other places, is the patient movement and sort of incomplete treatment. If records are not going with a patient from point A to point B, and you don't know if they've been screened for any type of resistance genes, if you don't know what they're infected with, this creates, I think this definitely adds pressure to the development of and spread of resistance. We've also seen with these patients, when you have them, we've heard a lot of reports too. We have people coming in from outside of Ukraine to provide support, and they bring with them antibiotics, and they kind of hand those out like candy, very unknown circumstances. It's not regulated. And this is the introduction of another variable that I think further complicates the problem. And you have this sort of inappropriate use of antibiotics in a very challenging situation. It's extremely difficult, I think, to control that. Regardless of what regulations you have in place, there's so much need, I think, for outreach and education to all levels of providers across the One Health spectrum about appropriate use of antibiotics and when you should use them and really when you should not.
Dr. Khan.
If I may add on this issue of lack of proper medical records. So, and again, we need to be thinking of innovative approaches. So one example is the Global Health Institute and the American University of Beirut. They've come up with this, and I think Dr. Busetta was part of this. They came up with this mobile electronic health records for refugees. It's called Sigilli, and it's a cloud-based electronic health records where you include the data on these refugees, and then wherever they move, they can have some records on their colonization infection. This was published in Lancet, I think. So again, we need to think about innovation on what can be done in such difficult settings. Over.
Thank you. Dr. Fight.
Just to follow up a little bit on Lucas's question, I'm curious how much evidence there is or what data you all are aware of either colonization or reports of AMR in any veterinary species in any of these areas. You've summarized very well in a very short period of time a huge amount of data, but I'm also, and part of it is, can we answer some of those questions, but also do we actually know what is going on in either companion animal or livestock species in the food setting or in the companion settings? Yeah.
Yes, so for Sudan, we have again very few data, but this was for the pre-conflict era. So, but for the animals, again, due to the large amount of the livestock, we have few reports of the colistin-resistant Acinetobacter. Again, this is due to the unregulated access to the colistin, yes. And for the salmonella, because it really represents a huge problem in Sudan, especially, you know, for the farmers there and their reports of third generation resistance. Now, after the war, we're receiving the very few cases of brucellosis, but again, we cannot test for it so far. And maybe not related to AMR, but rabies. We're now seeing a large number, yes. And this is mainly, if you know, back to the question of for children, mainly the reported cases. Most of them are among children. What we're hoping for, you know, for the again the upcoming period, that we can test for both, you know, the animal livestock and for the human. But again, you know, the conflict is preventing from having this, you know, the stable lab settings so far.
If I can add to that, we do not have, from what I'm aware of for CDC in Ukraine, I'm not aware of actual lab diagnostic testing looking at rates in livestock production animals or in companion animals, but we have done some assessments actually looking at antibiotic use by veterinarians and farmers, for lack of a better translation. And realistically, what drove their use of antibiotics was they had very little, or their selection of antibiotics rather, is they had limited access to susceptibility testing. And so labs were too far away for them to actually send samples off. And so they would just use antibiotics, and at a certain point in time, if that was no longer working, then they would transition to the next one. And so that was really sort of what we've seen there, is that access to the information about what is the appropriate antibiotic was really driving a lot of the choices that they were making over.
Dr. Abusita?
So there's evidence from the pellets of migratory birds in the region that there was antimicrobial resistant bacteria grown from the pellets of migratory birds. And we also need to understand the water currents in the East Mediterranean. The East Mediterranean current will travel from the front of Gaza all the way up to Lebanon, all the way Syria, round Turkey to Greece, and then to the coast of Italy. And that is with the breakdown of water and sewage treatment, both in Gaza and in Lebanon. That is also going to be a major vehicle for antimicrobial resistance spread.
Thank you. Dr. Dixon, you have a question?
I had a comment earlier, but I wanted to change it to a new one I just thought of. And that is asking you, Dr. Wong, if you think the research you're leading now with funding from us and previously from other agencies on, I'll call it computer-assisted and trained algorithms based upon prior epidemiology at your institution of species and susceptibility could be deployed in these settings where not the turnaround time to send out isolates for susceptibility.
Would any of you like to comment on whether or not you think technology could estimate risk in persons and be deployed without having to do the microbiology?
And maybe you could explain what your approach is.
No, I've got a patient if you want to pop in that one.
Oh, sorry. Dr. Hammond?
No, it's okay. So if I got it, the use of the high technology for estimating the risk?
I'm using algorithmic data. So you would need data to start with, but to look at risk factors and to try to apply that if you are unable to have laboratory services. I think that's what the question is.
Okay. So I think, yes, it's doable, but again, from my point of view, maybe in the refugee hosting countries, not the conflict country itself. I think it would be more easier and feasible. For example, as Dr. Kanjo was saying, in Lebanon, I think that would be, because they have the baseline, they have the data. But if I'm thinking, for Sudan, we don't have the baseline itself, to use it for future estimates. But for other neighboring countries, maybe yes, it can be doable.
And Dr. Kanj, you were talking about the EMR options.
Yeah, so I think a couple of things. I think machine learning, artificial intelligence definitely can be used even in such settings because we can feed data and it can predict what type of resistance mechanism you can have in these infections. But also, I think, standard microbiological diagnostic tests can be very difficult to achieve in conflict areas. So we're actually looking at, writing a concept note that will be coming your way for Welcome Trust funding, but looking at the use of molecular techniques that can help us decide what is the main problem with MDRO, for example, in a particular setting that can help us design algorithms, et cetera, for the future. So this is definitely something that we are currently considering, as the traditional microbiological test can take a lot of time and would require a lot of expertise to be done on site, whereas for the molecular tools, it can be collected and then shipped to neighboring countries where technology can be performed. Over.
Thank you. And these innovations are so important, innovative thinking. Dr. Craig?
Thanks. And I do want to extend a thank you from CDC to Joanna Gaines for her speaking today and for representing the agency so well. So thank you for that. I do want to underline for the committee, and I think just flag for comment from the panel, that the thing that we haven't talked about today, but I think is a prevention modality that could be applied here, is work on developing decolonization products and agents that could be applied in some of these settings. I think the issues that we see and the issues described here, we have significant contamination of individuals coming in. We have significant transmission onward in healthcare settings. We have healthcare settings where infection control cannot be optimized. And if we had decolonization products that could reduce or eliminate that microbial load for individuals, either externally on the skin, in the environment, in the gut, that could be a major pathway in terms of improving some of the outcomes that we're talking about here, and improving and stopping some of the onward transmission. So I guess I would just sort of flag that for the committee, and then welcome any comments from the panel on it.
Dr. Kanj?
Yeah, thank you very much, Dr. Greg. This is a great point to consider, but I can share our experience with using chlorhexidine to decolonize a patient when we had an influx of Iraqi patients with wound infections, and we tried to use chlorhexidine for decolonization from their multi-drug resistant pathogens, and we were really unsuccessful. And so our concern was that these pathogens are developing chlorhexidine resistance because of the huge load of organisms, and this is something that we are studying currently. So I give one other example for decolonization that we've attempted to do, not from patients, but from environment. So we currently use hydrogen peroxide vaporized in the rooms to really decolonize the environment after a patient leaves a room and when they have MDRO, such as Acinetobacter. Over.
Thank you. We're going to take one last question from Dr. Zagman.
Thank you very much. I wanted to take this opportunity to thank all of our panelists for the very, very important work you do and for taking the time to present. Just a round-robin question for all four of you. So if you had to prioritize three things, assuming there are resources and means to do so, what will those three things be?
I can start. If I want to prioritize three things, I would say vaccine availability, training, and point-of-care testing for understanding the epidemiology of AMR in particular settings. Over.
Dr. Haynes?
I have two. So the first is fairly broad, but really focusing on information sharing. And this includes surveillance and making sure that we have these networks established in advance. I really appreciated Dr. Hamid's comment about using cold zones and really providing that proof of concept. That's what we've done in Ukraine with our pilot facilities. And now that we're seeing that things work there, it's time to move closer to the front. The second thing I would really, reiterating Dr. Kanja's point is IPC is everyone's job. And this needs to be, we need good evidence-based training methods, so adult learning methods, aimed at all types of providers inside the facilities, outside the facilities, thinking through how can we make this accessible to someone who has not even the equivalent of, say, a high school education. And I think that that's really important. We have to meet people where they're at with culturally appropriate messaging and be able to tailor our trainings to those different settings so that it stays culturally relevant and salient and is actually applicable in the real world. I mean, this is the difference between kind of public health and academia. This is where the rubber meets the road. And so I think focusing on those two things, information sharing, from patient, with regards to patient care, but then also making sure that information is shared amongst different public health parties, and then really focusing on high quality evidence-based IPC training for all providers.
Well, for me, first priority is prevention again, and prevention to be put in very simple messages that can be, translated or be translated by community healthcare workers, because again, they are the one who has access, or they are present on the ground. The second priority would be the access to the antibiotic itself, and this is one of the initiatives that we're trying to do with the WHO is to optimize the antibiotic content of the health emergency kits, because I know it's updated regularly, but it needs another second look, especially for conflict zones areas. The third point, actually, it's that trying to advocate among, the health clusters in these conflict countries that, again, AMR is a priority. It's not only developmental issues. It should be integrated. It shouldn't stand as a vertical standalone program. Actually, it should be integrated within the other programs, within, vaccination, child health, maternity, emergency response, because this is very crucial and will mobilize, some funds for the activities.
Dr. Obisita, would you like to give your top 3?
So for me, it's moving away from systemically administered pharmacological solutions to locally active topical solutions. Solutions as in, answers rather than solutions as in liquid. Point of care diagnostics. And third, nursing and medical, but worse, medical undergraduate education really wastes a lot of time still chasing that 1 in 3 million congenital abnormality, and does not teach enough IPC. And I think it should be in the first clinical years. IPC should be drummed in as a core component, not of each and every one of the subspecialties and the specialties being taught in medical school, so that it's not something that's on the side, or that you have people trying to chase them after they become doctors to try to teach them these things. And that needs to happen at the level of the WHO, instituting that kind of change in medical education in countries, lower and middle income countries where these things have the most devastating effect.
Thank you so much to each and every one of our speakers. We'll close this panel. I'm going to return it to Dr. Musmar.
Thank you so much for moderating, Dr. Wong. And I know that we were a little over, but this conversation has been fantastic. And we thank all of our presenters for sharing their expertise with us today. We appreciate your insight, and hopefully we'll continue this relationship as we discuss this matter further, potentially down the line. Thank you all for being with us. We're going to take a 20-minute break for the council. Oh, Dr. Kanja has one more thing to say. Yes,
I just want to reply to Dr. Busetta that at WHO, we're currently, I'm part of this team, we're finalizing a document for AMR to be part of the curriculum of every medical school across the globe. and this will be finalized very soon. And so I just wanted to bring some good news in this session as well. Thank you.
If you're going to put a plug, we're going to put a plug for Dr. Plummer's report also on interprofessional education and core competencies. We have a PACCARB report that also emphasizes the need for that as well. So we're all pushing for the same message is what it sounds like. Thank you all so much. We appreciate it. See you at 1:20 for a prompt. Did I get the time wrong again? I'm good? Okay. Yes. In 20 minutes, regardless. See you. For our council members, you can join us in the break room for coffee and tea.
Produced by the U.S. Department of Health and Human Services.